cohesive message to go out to all healthcare practitioners, but specifically to policymakers, to say there needs to be a target, and this target is mental health, and specifically anxiety and depression tend to be one of the biggest drivers of disability-adjusted life years in all healthcare practice. We got a group together for the WISH. Most of the people from our group were also members of the Lancet Commission, and we were able to take the work of that Lancet Commission to the next level, which was to come up with practical solutions at a country level. And we came up with 3 core messages. The first message was that most people who suffer from mental health disorders also suffer from concurrent disability, or vice versa, so that most people with chronic conditions are also suffering from mental health. This happens in about 2/3 of people with chronic conditions. And so you cannot just distinguish someone to see a diabetologist at one hand and then ignore the mental health side of things. Or say, here you are, you have a chronic condition, please see someone who's an expert in this field, and then at the same time go and see someone else who's a specialist in mental health. It doesn't work that way. You need a coordination of care, and this is brought about in something called the collaborative care model. One very successful model is that in the United States from the IMPACT platform. Here, people with chronic health conditions are seen with both a specialist in a particular field where the pathology of a patient's chronic condition lies, but at the same time they're seen in the same clinic at the same time with someone who has an ability to appraise and hopefully treat an associated mental health problem, so that people are not seen as just one disease in one clinic and another disease in another clinic, but how there's a more holistic approach. And that holistic approach derives from the collaborative care of the practitioners offering the care to them. Secondly, there's the issue of stepped care, and I'll talk to you about stepped care in a little bit of depth. The first thing to say is we do have treatments for mental health, and we do have successful pharmacotherapies. This is a network meta-analysis from 2018, and using a Bayesian probabilistic model highlighted the fact that nearly every antidepressant does have a successful benefit in a randomized setting compared to a control group. Whilst this is important, it is not the only solution to mental health, and we cannot just assume just because there is efficacy in our pharmacotherapy that that's the only treatment that we should be offering our patients. So in a stepped care model, there is a need to identify a staging of care that is opposite to the level of mental health needs that a patient might have or a population might have. Sometimes you might need to go to a primary care practitioner who understands you're suffering from mental health disorders, but you don't need to have aggressive pharmacotherapy. You might need someone to talk to. You may need someone to give you psychological intervention. Sometimes watching and waiting is appropriate. Sometimes it isn't, and in those cases, then one might be able to be stepped up to pharmacotherapy. And if that's not appropriate, then you can be stepped up to psychiatric review, and you can be stepped up to psychiatric inpatient stay. But that's not necessarily one size fits all. So for the stepped care, you have a stage appropriation of your care to be able to manage your condition as you go further down the severity of your pathology. And there are examples of this. The IAPT in the United Kingdom, the NHS, is a very good model of this, where you're having the improving access to psychological therapies model. And here in GP practices around the country, people are identifying that actually mental health disease is a population level issue. It is one of communities. Not everyone has to be rushed to be given medicines. Not everyone has to be rushed to hospital, but there should be ideas and solutions at a population level to say, we should have group meetings, maybe come back to the clinic once in a while. What is your background like? Maybe I'll put you in touch with someone that has a similar condition that you might want to talk to. And so you stage your care according to the needs of the population. And in the NHS, this is beginning to pay dividends, and we're watching the results to see if this will have long-term benefits. One major issue for stepped care is having a staged approach to care within your workplace. More and more people are spending more time at work. I certainly spend more of my day at work than I do at home, and my colleagues at work are actually a source of relief and support for me, but they could also be the ones who highlight the fact that I might need to be looked at from a mental health point of view. And some of the work we did with the World Innovation Summit for Health was to highlight how much of the time people spend at work could be affected by their conditions of anxiety and depression, and how that has a downstream effect. So we looked at two things. One is absenteeism, which most people understand, which is essentially when you're so unwell from mental health that you need to go home or not come to work. But actually there is something called presenteeism, which is, on the other hand, a lot of people attend the workplace suffering from mental health disorders, and no one seems to recognize these, but these have a massive effect on functionality, on well-being in the workplace, on productivity. And it has been modeled mathematically to highlight exactly what proportion of GDP can come from both absenteeism work from anxiety and depression, but also decreased productivity due to being present at work without having the appropriate support. And for example, in the United States, £84.7 billion dollars is lost every year by people who present to work, are going through the day-to-day routine, but not really being productive, but being in the state of anxiety and depression, which no one is really recognizing. And so one of our aims was to say, well, what can we do to highlight this at a workplace? Because it is part of the paradigm of stepped care, where your community sometimes is helping you. What about the work community supporting you? We did a questionnaire, and we said around the world, USA, Germany, China, India, and Qatar, and said, what would happen if you had a colleague at work who wanted to talk to you about their anxiety and depression? How willing would you be to engage with them? And what was staggering was that up to 20% said yes, which meant 80% or more said no. And this was a rather frightening statistic, to say that people weren't really willing to engage with this condition simply because there is a national stigma associated with it. And this is not just one country, this was across the board. And so we thought this was a crazy figure, and could we put a number on it? And it was something that we felt could be addressed. And if it was addressed, we highlighted the fact that for every pound put in, you would get 2.37 pounds of savings downstream if you were able to address these things in the workplace. And so there was a return on investment over 200% essentially if you were to address anxiety and depression in the workplace. So stepped care at work is something that we highly encouraged, and particularly in the fourth economic and industrial revolution, where people are spending and encouraged to spend more time at work, this is something that we feel is an important topic to engage with for the next 50 years or so. Our last practical solution for policymakers was to talk about task sharing. And that means not everyone has to be a professor of psychiatry to be able to sit down and manage with someone their issues of anxiety and depression. In fact, it's rather the opposite, that it needs to be something that we all as a community have to address. And so we have to task share as a group. It comes from the paradigm of psychotherapy, where psychotherapists tend to offer care to individuals, but they also have to go to psychotherapy themselves. And so it's a group effort that addresses societal anxiety and depressive needs. And to the same extent, this is something that we highlighted in the Wish report, but the golden nugget, the golden exemplar of this task sharing comes from the kufugisisia word in Shona, which means thinking too much. And this is a Zimbabwean term, it's used somewhere in Zambia as well, where people who had anxiety, depression were considered to have this, were associated with this term. And a bottom-up system came up to place where you had something called the friendship bench. Some of you might have heard about it, some of your children might have had this introduced into their schools. I know Nicolette's child's had this introduced in her school. And this is where people at set time of the week will come and sit on a bench, and people who are suffering or wanting to talk to someone about their personal woes or their anxiety, depression can come speak to a stranger, free at the point of source, free at the point of care, no stigma associated. Sit down and explain your woes away and see if someone can help you. Someone could be more experienced in some things than you, someone might just be there to listen to you. Nevertheless, it has been a massive success, and it has been appropriated by up to 1.8 million people in Zimbabwe, and it's growing, and it has now a worldwide following. And so it wasn't just us that highlighted this, but we thought this was a fabulous exemplar. Last but not least, as part of our report, we said none of this would be possible without addressing that fourth industrial revolution, which is adopting a digital platform to be able to enact these three areas. And so we pushed the direction of digital care, and I won't be the one to do that for you because all the remaining three speakers will do that, and I don't think I have enough time to do that. But it is probably the thing that now underlines everything that we do, both in terms of the fact that everything's becoming digital in terms of our electronic health records, but also the fact that we all seem to have a smartphone with us everywhere around the world, and this seems to be a source for us to communicate with the outside world. In conclusion, we suggested that to enact these three routes of care, there needs to be situational analysis at every country level to identify what the real opportunities are and what the resources are. Secondly, there needs to be a prioritizing of which targets one needs to go for, because not every country is the same. As I said, no one size fits all. And three, you need to have realistic implementation strategies, because different countries have different routes to do this and different levers. We think this is a start. It really is something for discussion, but I hope that you've learned from the process that we did. We are trying to push this paradigm beyond just the WISH group, and we've already had some positive traction. The take-home message from the WISH was that Michael Phelps was, the superstar that came to talk about his problems with anxiety and depression. He said something. He said, I was the most decorated Olympian in the world, but when I was by myself, I was suffering on the inside. Now, if that's the most talented Olympian in the world saying that, it's something that we need to all consider, and it's a population level solution that will answer it. Thank you very much.
Thanks very much, Hutan. It really sets the scene, I think, also for the rest of the speeches. Does anyone have any sort of burning questions for Hutan, or we can take other questions later in the panel discussion, as I said? Okay, great. So I'd like to introduce myself, and Dr. Fiona Pina will give the next presentation. Fiona is the Chief Clinical Officer at Mental Health Innovations. She has over 30 years experience teaching and counselling in schools and higher education institutes. You may know this face or know the voice when she starts speaking, because Mental Health Innovations, as she will discuss, has recently launched Shout, a crisis text messaging service, and we launched last week, and Fiona has been on TV and on the radio quite a lot over the last week, so very exciting times. And she's responsible at Mental Health Innovations and Shout for ensuring very high standards of clinical direction and practice. And she has a PhD in behavioural science from the University of Auckland as well. So I'll hand over to Fiona, who will explain the wonderful digital intervention that is Shout, and sort of the global reach that is being created through a network through Crisis Text Line in the US as well. And then I will explain a little bit about the partnership between Imperial and Mental Health Innovations, so that we can extract insights from this service that will then feed into the wider mental health sector and the next generation of tools. So thank you, Fiona.
Thanks, Emma. Yeah, it was like 15 minutes of fame. The only person who said anything to me was my hairdresser on Saturday. I saw you on television. It was great to hear Hutan's talk, because it just felt like you could see where we fit in. So Mental Health Innovations, let me go back. Mental Health Innovations is a legacy project out of what was then the Three Young Royals Heads Together campaign. You may remember that 2016 ended mid-2017. They worked with Imperial to look at the data, and then they were interested in how do we continue what the focus of Heads Together was, which was to lower stigma and get people having conversations about their mental health. So they were interested in how do they do that at scale and continue to give people opportunities to have conversations. And obviously the way they thought was to go digital. So the first program or intervention they brought in was Crisis Text Line. So Crisis Text Line has been running for just about 6 years in the United States. So it's an established way of providing a service, a population health service. this is just a bit of background, and I feel like I'm talking to an audience who'll know these sorts of stats, but particularly interesting for us because our biggest demographic at the moment would be 13 to 25-year-olds. I think that is because of their feeling comfortable using text and using digital, but it's also, I think, slightly skewed by the partners we have piloted with for a year who tend to focus on youth, especially The Mix, which is a charity that works with 13 to 25-year-olds, and then after that, Young Minds, Place to Be in their secondary schools, and then other partners that have come on subsequently. But we do find we are getting a lot of young people talking about emotional and their problems in coping generally. So we rebranded Crisis Text Line as Shout because we felt that the word crisis was associated with a lot of other things in the UK. And we did a whole lot of branding around the 3 dots when you text, so that was fantastic. And we actually went out public on Friday. Our primary focus was to get more volunteers because it is a volunteer-led intervention. And let me just say at the outset, it's all texting. We are not a counselling service. We are a de-escalation service. So we give our volunteers 25 hours of online training. It's really good. I've been through it. Been in this field for a long time, but I learnt a lot. We've got one of our clinical supervisors here, Ariel, who's nodding at me, so I presume she learnt a lot too. Yes, so we're not a counselling service, but we do have a team of clinical supervisors on the platform who are overseeing the conversations. Because while we like to think that we best serve that section of the population that is just starting to tip over and not have the resources to cope or not feel they can talk to somebody, we actually are getting a lot of people who have already got a mental ill health diagnosis. So we have that clinical team. The volunteers are on the platform. They're supported by a personal coach as well, so there's a lot of support for them. And basically the de-escalation model is a humanistic approach, so it's very much rapport building, identifying the goal, what you want to get out of this conversation, and then we have a very curated set of signposts on the platform. So at the last stage of the conversation, they can give them links to refer themselves into more specialized services, charities, or statutory services. In terms of defining what a crisis is with Crisis Text Line and with Shout, it's really self-defined. And at the point that we took on the platform, which was just after Canada last year, is it last year? Yes, last year. So it really is about how somebody defines a crisis themselves, but they've got to a point where they can't cope. So that was part of our branding. So direct messaging, and that's, I think, what makes it so good for people, is that it's instant, it's private, it's quiet, it's confidential, and they can do it 24/7. In fact, our texters, the numbers scale up after 10 o'clock, so I'd say between 10 and 2 o'clock in the morning is when we get the most texters. So it's a proven technical platform license from the US. We partner with them. They give us the platform. We had to change quite a bit. We had to change all the videos in the training to be more UK friendly. There were certain things around safeguarding and terminology and legal stuff that we had to change as well. But what we get is an amazing platform. So it's the AI has been collecting data obviously for nearly 6 years, and it does things such as it assesses the first text that comes into the platform. It looks at the language, and then if it identifies language which is likely to be an imminent risk conversation or lead to an act of rescue, because we do work with the police, it pushes those conversations to the top of the queue and they are taken first. So that is one form of assessing and keeping an eye on where there is risk. Obviously the other side is the training of the volunteers, but more importantly, the clinical supervisors on the platform. So what's fantastic for volunteers is that they can do it at home. They can do the training at home, they can do the work at home. We have some organizations we've partnered with, and people in a big sort of banking corporation will do the training, and then they'll have a room where they can do some volunteering during the day. So it's a really good model in terms of volunteers. They don't have to get in their car and go anywhere. And yes, I think we've had a successful launch. So we had a drive on volunteers. We had a media discussion at Kensington Palace on Thursday, and the media were really on board with not actually talking about the number that much, but rather about volunteers. And by the end of the weekend, I think we had 11,000 applications to be volunteers. So we had hoped for about 5, and then knew we'd probably get 1,000 out of that. So we have got 1,200 volunteers at the moment, some of who've been with us for a year and have become very skilled. You see them talking in the chat rooms on the platform about wanting to study further. We feel we are actually contributing to the mental health workforce as well. They talk about how what the skills they've learned ripples out into their personal life and their professional life. So yeah, we've got all these applicants, and then from Monday, we started putting out the number, which is 85258, if anybody wants to use it or pass it on or have an experience, what that is like, and the website, which is giveusashout.org. So that's a very vague view of the platform. We will, I don't know, Ariel, if you've got your laptop here, but I'm happy to show people the platform if they're interested. Just quickly, and give me a sign when I've run out of my 10 minutes. So we've done 70,000 conversations just in our pilot year. So it's been the percentage of active rescues, which is when we contact the police, and we've worked all year with the Met, and just about 2 weeks ago they gave us a dedicated number to call into in recognition of what we're doing, and the fact that by the time we call them, it's gone through a whole lot of assessment. The supervisors have made a decision that yes, we should call this in, and we call in under 3%. So I think, you know, that's an indication of, I think, how good we're getting at de-escalating. Every time a texter texts in, their information goes on their profile page. So we have we have data from 70,000 conversations, which is very exciting, and we're very excited to be partnering with Imperial to explore that and see what we can do with it. 26 clinical supervisors. Excitingly, we have 4 in New Zealand now. I came back about 2 weeks ago from training them. The good thing is about New Zealand is that they have accepted GDPR status with the EU, so data can flow, and they have really made a difference to our sort of post-midnight shifts, because then it's daytime there, so that's made quite a difference, I think, and we hope to increase that team a bit. 5 coaches, they all look after, I guess, about 200, 250. We're upping the numbers as we get more volunteers. And the age demographics, mostly 18 to, not mostly, but the biggest demographic, 18 to 24. I think, interestingly, the 13 and under is quite a fast-growing demographic, and we know that the average age of getting a mobile phone in the UK is 10 and a half. The US, it's 10. It does bring up issues of how we handle those texters, safeguarding, all those sorts of issues. Since we've launched, I've seen a slight increase in older texters as well, which is, it is a population health service. These are the top presenting issues as tagged by volunteers and supervisors in the feedback form, not feedback form, what's it called, Ariel? Yes, post-convo survey that flashes up at the end of every conversation, and suicide ideation being our top presenting issue, and that sort of stayed pretty consistent throughout the year. I do think that may be again skewed by, we have quite a I think stressed cohort that come out of some of the charities we work with, and basically if you go, say the Mix is our main charity, was our main charity throughout our pilot. If you are one of their 3 million users, then you go onto their website and you go into help, and if it's say after 10, it might say our helplines are closed, but if you need help, text our crisis text line service, the Mix 85258. So it won't say shout. They've got a white label or there's another word for it. You know, they've got a word that identifies them. So their texter, the people that use their service text in with the Mix 85258, meaning that we can aggregate all their data back to them. Just quickly, this is the daily conversation. So we had a tricky year in that we didn't want to raise the number of people who knew about the service while we were growing the number of volunteers. Over here, that was Christmas Eve, when some kind person put on their Instagram page, did you know if you text 85258, you'll get a volunteer on the other end who will talk to you. And Christmas was cancelled for a lot of people, a lot of us at the service. We went up to, actually was nearer 700 conversations, and we turned down our Google AdWords, and we turned down everything. So, and this is where we are now since we've launched, and you can see there was a nice matching until Christmas Eve curve. What was interesting about the Christmas Eve spike is that it was a lot of curiosity. And people saying, oh, just checking if this is for real. And in fact, over that 24-hour period, I think we only called in 1 or 2 ARs, active rescues. So it wasn't a cohort that was particularly stressed at that point. Yes? Time up. Okay. This is just showing how we will grow where crisis text line is and where we are in the UK. Just click through mine.
Thank you so much, Fiona. We've sort of got a two-part presentation here, so still on the same topic, but I think it's an incredible service and a way that is really meeting a need of young people in that moment of crisis, how they can be supported from that crisis point to a much calmer place. And so while the service is doing incredible work, and I think we can discuss maybe in the panel discussion how it's also going global from the US, now it's Canada, it's going to be Australia, South Africa, and how we adapt such a service to different contexts and beyond. But the other side of the service is that, as Fiona said, all of the conversations are kept, obviously anonymized, but then that data set provides quite a unique insight into people who are not accessing traditional services potentially, but who obviously have quite a high mental health need. So we're able to hear directly in their voice and really hopefully develop some interesting and very important insights. So just quickly, we can go back, but this is sort of following Fiona's all the incredible work that Shout does to really, really help people. So what I'd like to talk about is just going back a little bit of why is this data set so important? So as we said before, we know the rates of mental illness are increasing, but actually there's still a really large knowledge gap of why these rates of mental illness are increasing. Who is being affected? What are their lives like? What are their needs? And what are the implications of this for healthcare and other social services? So we currently have a really big knowledge gap. We still don't really know the circumstances that are influencing this mental health crisis. And hence we don't fully know how to address it. We don't know about people who aren't accessing traditional services, and we lack big data sets that are actually being used. So Professor Simon Wesley said, we have a long list of plausible villains of what's causing this crisis, and these range from social media, bullying, debt, changing parenting styles, exam pressures, loneliness, but frankly we don't really know for sure. So that's sort of problem one. Sorry, I'm struggling to click through here. Here we go, okay. And so the problem two that is connected to this is if we don't fully understand, how do we find the optimal evidence-based ways to address this crisis so we can develop tools and solutions that are in response to an identified need? And so what we need to do is have evidence-based interventions that have user-centric design. And as I said before, there's a plethora of health apps available, but most of them are not being used and they're not generally evaluated. And there's a lot of literature emerging around this that basically very few of the tools that are out there have been well studied or validated, and we have little experience with their impact, and we have a frequent lack of an underlying evidence base, and this is a growing sort of call in the literature. And so to address this, we really need data. To understand these problems, we need access to appropriate data sets. We have limited big and well-connected data sets, and a lot of the data sets that are sitting there are not being used. And so we need to keep calm and we need to use data wisely is, I guess, how Shout works. And so one partnership that can be working to address these issues is Fiona and the rest of Mental Health Innovations have this incredible, growing, unique data set, and we can connect this to the amazing work that Imperial does in big data analysis, in user-centric design, and our policy expertise. And so as an example, I've been working with Mental Health Innovations sort of in the lead up to the launch of, I guess, understanding a bit more about some of the issues that people are feeling. So there's a picture that's missing there. But so I've been doing some analysis in the lead up to the Shout launch based on the data over their year of piloting the service, just to give some quick insights. And so we found that in the conversations when people first texted in, the most common feelings that they identified were feeling scared and feeling alone. And when we pulled this out of all conversations, 20% of conversations talked about being scared or anxious or afraid, and 16% included one of being lonely or alone. And how the model works, as Fiona said, is that in this case, volunteers respond with support. And again, we could start to aggregate the data and look how volunteers are responding to texters, and so how this intervention is working in practice. And we found in 32% of conversations, volunteers reply to texters that indicate the strength of the texter for seeking help. And in 41%, they mention how brave or courageous they are. So there's this sort of validation of what they're doing and the strength. And this is really well received by texters. So volunteers help texters also make a safety plan. So they not only support the texter and hold the space for them, but they help them sort of co-develop this plan. And we could pull out these word clouds of aggregated, what are the most frequent sort of phrases in response to that sort of safety planning from texters. And they talk about trying to distract themselves or listening to music or keeping themselves safe. We can start to see some of the themes that are emerging in how they're developing that plan. And texters are really responsive to the volunteers. So the most common phrases that get pulled out when the volunteers mention how brave or courageous or strong they are is they say, "Thanks, that means a lot." And when you look at the texters' feedback to the overall service, the most common 3-word phrase that gets pulled out, it's still a small proportion, obviously, with this particular phrasing, but it's helped calm down, which really shows that the service is de-escalating. And so this was just some sort of first insights that we were using to sort of understand the service in the lead up to the launch. But sort of stepping back, once we have this growing unique data set, there's a lot of questions that we can start to drill down into. You know, why are the texters experiencing a crisis? What other avenues of support are available? What are they using? How does the training affect the volunteers and the volunteer side and the intervention from their perspective? And how does the intervention work, obviously, from the texter's perspective? How does the service impact them? What demographics are over or underrepresented? What issues are being raised that are not supported by traditional services? And then that might identify actually areas that we could develop the new innovations. So the ambitions for this partnership are really to use this, obviously, anonymized data from Shout and other partners, potentially in the future, and through this, generate a greater understanding of the issue and really identification of the needs. And this can lead into policy and insights for the whole mental health sector, but it also leads into a development of targeted innovations that we co-designed with the users in response to that identified need. And then, of course, we need to evaluate the innovations and interventions, but also those digital tools and services in and of themselves may generate more data, more insights that can feed back into this loop. So we really want to kind of revolutionize what's happening in this digital mental health space, so we get away from putting tools on the market that aren't in response to need and aren't well validated. So this is the ambition, and we're really excited to work towards that. So thank you very much.